now we're gonna move on to another couple participants who have their own amazing wealth of knowledge and experience, Ray and Roger. So let me introduce Ray and Roger, and then we're going to have a bit of a back and forth with Ray, Roger, and Marchello and myself, sort of throwing some questions at them and digging into their experience, opinions, and and some of their plans and the work they're doing to help with COVID-19. So yeah, Roger, first of all, Roger is a MD, a cardiologist, certified in cardiovascular disease and internal medicine, knowledge in all sorts of cardiac imaging, nuclear cardiography, echocardiography, coronary angiography, and so forth, and also passionate about bridging technology applications with medicine to bring AI to healthcare. And I mean, diagnostic imaging is already extremely helpful in his field of cardiology to deal with congenital heart disease, heart failure, arrhythmia, and so forth. But the application of technology potentially goes way beyond that, and we're going to dig into that a bit now. Ray, and also an MD, he's been owner of a family medical practice in Vancouver, and has spent a good deal of time on other aspects of the health of the whole organism besides traditional Western medicine. So studying mindfulness, meditation, integrative medicine, holistic forms of wellness. Is also a blockchain developer and a bit of a computer hacker and a geek on the side, as well as having this whole integrative medicine and MD background, and which is how we have intersected via my work with SingularityNET, bringing AI and blockchain together. I organized a hackathon called COVID-a-thon, and some software that Ray and Roger have been working on called NTH Opinion has been developed in collaboration now with SingularityNET and some folks in COVID-a-thon, and we'll dig into that in the conversation. So we've had a few talks really deep in the guts of simulation modeling, and the talk after this by Deborah Duong will also be sort of deep in the guts of simulation modeling. I think with Ray and Roger, we're looking more at picking their brains for their wisdom about COVID itself as physicians, and then they're thinking about broader uses of information technology to make a better medical and pandemic management ecosystem. So yeah, with that, yeah, let's introduce Ray and Roger, and I think we'll bring in our old friend Marchello as well to help drive the conversation.
Thanks, Ben.
Thank you, Ben, for introducing Ray and Roger, and thank you guys for taking the time off and joining us at the COVID Simulation Summit. It's a privilege for us to have you here. So Ben gave a great introduction of your background. Do you guys want to spend a couple of more words about your current projects and what you guys are up to recently?
Yeah, absolutely. I think the meeting with Ben has been actually a very seamless integration. I think we learned a lot from him, and the technology is incredibly comprehensive. What he's built, a full stack AI developmental platform, was pretty much exactly what medicine needed. We just didn't know how to get in contact with Ben, and it was lucky that your team came and found us. We've been hard at work trying to build the stuff and the tools that medicine really needs. We have a lot of data, and more what we realize is that a lot of clinicians and how clinician practices is more like a linear algorithm, right? We really try to trajectorize point A to point B, whether a diagnosis equates to a particular prognosis, whether an intervention relates to a particular intervention. And we'd like to say that from a clinician standpoint, from a human standpoint, we can reach that. We've got tons of studies. Some of those are in their hundreds of thousands of patients randomized to multi-center control trials. But what we realize is that a lot of those studies, when you apply them to the clinical setting, they either don't apply well, the patients are not represented well, or for some reason, your results are not exactly what you perceive them to be. So it very early on, from a couple of years ago, what we realized what AI was able to do for us was be able to take in parameters that are far more subtle than what doctors typically see. In cardiac imaging perspective, you can take an entire image of pixels, which are far more detailed than what a cardiologist typically pinpoints in the image, right? Let alone pixel intensities that even cardiologists don't necessarily pick up. So from that data standpoint, what we really wanted to know is can we get from our multi-modality, multiple data point entry, and come up with a nonlinear algorithm to reach a diagnosis, to reach a prognosis when there's an intervention at play. And we felt that AI was really an incredible technology that can facilitate that better than anything else has.
Now, in having years of conversation with Roger, who also happens to be my brother, so discussing the tech side of things and how it intersects with medicine has been a passion of ours for a long time. And, as we all know, software is eating the world, but healthcare has been rather ossified. It took, for better or for worse, it took a pandemic to really shake things up and realize that we were in a very fragile system. The healthcare system itself is very siloed. The information doesn't flow freely. It's unclear on, it shouldn't be, but it's unclear on data ownership, accessibility of the data, transferability of the data. And so as Roger and I were having sort of deep conversations on a lot of these siloed data problems, along with analysis and then the utilization of the data, what kind of came to light, and which is a passion of mine, is a couple of things. One of them is to actually decentralize and distribute that data. But then the second aspect of that is, once you have it, can you democratize its use? And so what kind of came to light over and again was, how can we democratize AI for the people and enable folks to regain a quick and easy access to the data so that they can do what they need and want with it. And that became particularly important for COVID-19 because as we started to develop a platform that was essentially just asking questions, you can kind of think about it as doctors truly working without borders at this point, because we started to run into barriers. We had the good fortune in hindsight of seeing what was happening in China weeks, months in advance, what was happening in Italy, South Korea, but yet the dissemination of the knowledge and the experience of frontline workers was slow, asynchronous, and unreliable. And so that was sort of where we decided to actually work on that, taking the speed at which the virus was spreading and figuring out ways that we could disseminate the knowledge at, we called it at the speed of code, because we did believe that it should be able to travel more freely. And Roger often talks about how our practice in medicine changed overnight. The speed of research was clearly not fast enough. The speed of no blame on anyone in particular, but just the way that information moves through PR and HR, bureaucracy and politics left a lot of frontline providers without the necessary PPE, treatment strategies. And so that's sort of how this culminated. And then, Dr. Ben and the SingularityNET team had reached out with some solutions already in the making and made. And so that was a great opportunity to collaborate.
Yeah, the pandemic is also interesting too. What more and more we realize is that, in particular, as I see patients, is that there are two groups of patients out there. You can almost think of it as two political parties, and the political parties really almost represented pretty well to a T. There are individuals that are very, very late to move. They are very resistant to governance and governmental rules. And those are the individuals that will have a tendency to really not enter into the social distancing protocols and recommendations and so forth like that. And then there are the other individuals that are very proactive, um, in almost to a point where they're a little bit overreacting to a certain state. And they will don all kinds of safety equipments. They will actually even be ahead of the recommended guidelines in certain ways. And absolutely separated by two sides. Very little in the middle. There are some blends in the middle, but in general, two very separate patient populations, and in fact, people populations, right down to the healthcare providers. So in my group, for instance, our leadership was very much against uh, taking the healthcare force and changing it in ways to protect them and so forth like that. Not necessarily because they believe that they don't need protection, but it's primarily because they did not believe that, whether they didn't believe that anything could be done or whether they didn't believe that the virus is a significant now deal, that part of it is really unclear. But in the end, they were very, very resistant to moving, very resistant to change. On the other side of it, you have a whole bunch of other healthcare workers that absolutely needed protection and so forth like that, and they needed to move fast. And that really clashed in the middle of it all. And we found that a lot of leadership, me, myself included, had a really hard time trying to figure out how to bridge the gap between the two without losing my own job, for instance, for that. So if I wanted to protect myself, I have to run against resistance with the other group. If I wanted to provide leadership for the group that wanted more personal equipment, the other group will be in conflict with that because it goes directly against their employment. So there's a large part of the talk is safety, and then the other part of the talk is economics. And they're almost completely contradictory to each other, even though they don't have to be. The two sides have a tendency to believe in one and not believe in the other. But what I found that worked really well with me and just a few groups of individuals just directly in line with me is that you can actually do both. But for some reason, you can't enforce that with the entire group of cardiologists. So what I mean by that is that in order to protect myself and be able to work at the same time, I really needed to push the limits in terms of barrier protection, right? I needed to be able to do masks, N95 masks, goggles, and potentially stuff for my hair and so forth like that. But I also needed to do video conferencing and so forth like that. But you don't necessarily need to pull the whole clinic offline. Ideally, if you pulled the whole clinic offline, that's safer for everybody. But if you did that, a lot of the workers that are under you will lose their job, right? So immediately you'll see that your nurses, your MAs and so forth like that, if you try to stop the clinic, or as a cardiologist tries to pull out of clinic, immediately you're under your direct people that you're working with or working for will have a massive issue about that. So in order to compromise for that, I needed to continue to work. So how I continue to work is as I developed a virtual space and did that. But not everybody is actually in line with that. And in fact, even though in the last couple of weeks, the lockdown has been very forceful in terms of locking everybody down. And I think Dr. Lee had talked about that, Eva Lee had talked about that. That was very momentary because the moment that Governor Inslee hinted at the fact that we're opening up, masks came off, hats came off. You know, even some of the guys in the very beginning that got tested over and over again, they you know, they're just standing in the hallways now without any equipment. And that comes at quite a cost. The classic example is what we were talking to our group yesterday about is we have one of our own colleagues actually are gone back into seeing patients in the clinic again, right? 20 patients, 30 patients a day. And immediately what happened was there was an exposure. And you're basically, right after the exposure, you're shutting down the entire clinic to clean the clinic down, and not to mention quarantining the doctor and all of his medical staff for about a day or 2 days waiting for the results to come back, right? So why do that when you've already had that done to you the first time? To me, it doesn't make a lot of sense, but that's the nature of people. And that's the kind of thing that we've been struggling with over the course of, actually, pretty much for the duration of the pandemic so far, is two different groups. So how we view our project is something that helps bridge and unifies the both groups in a certain way. Information flows from one group, depending on which group is more either ahead or has the upper hand in knowledge, and it flows to the other group. It can go quite easily the other direction as well. So if the other direction is not to move so quickly, and that turns out to be more beneficial, then the idea is to have either algorithms to make that adjustment and flow that information back to the other side, and sort of reduce the unnecessary hyperactivity or the overreactivity done by the other group. And so this system that we have is like a natural system of communication, not directly from person to person, but mediated by a platform where you're unifying two separate groups. And that's kind of how we thought about it. And in fact, what we initially wanted to be able to do was unify multiple countries. We did think that China would be much tougher to infiltrate, but we've had some success at doing that as well.
Yeah, one of the really interesting things that you're bringing up here is something we haven't yet taken into account in our agent-based simulations, but I think we will need to, which is just the role that culture has on how people are reacting to the situation. And I mean Eva brought that up as well. Like in Hong Kong, where I was until a month or so ago, I mean, there's not a requirement to wear masks, but almost everyone was wearing masks, right? And in general, being in China, Hong Kong, South Korea, I mean, we found that there's a strong inclination to, behave in accordance with public health suggestions, but not 100%. Like you couldn't stop the Hong Kongese people from gathering around a big red table in a restaurant when there's a family occasion. Like, no matter how dangerous they know it is. And then a lot of stuff was spread that way, right? So it was quite interesting to see when something's culturally important enough, then people will take almost any risk. But the rest of the time they were being very, very, very safe, and huge barbecues outside. And I didn't see the data showing how much safer it really is gathering around the picnic table, having a barbecue outside versus indoors. I'm sure it's a little bit safer, but of course these things spread as trends, right? If you drive by and see people at a barbecue, you're going to go there next weekend to have a barbecue. So the culture being different in different parts of the US as well as across different countries. So yeah, when we're trying to estimate the effectiveness different measures will have, like how to incorporate the information people have, and then the way they use that information and the way they imitate what they see other people doing. I mean, this all has to be part of the model and part of the simulation. And I mean, of course, that's complicated, which is why people aren't accounting for it so far. But if it's going to be like Eva said, and there's going to be a couple more years of mess having to keep this in control, then I mean, we're going to have to pay attention to this. I mean, yeah, that's one thing I was curious at, like from your point of view as sort of broad-minded systems thinkers who also happen to be MDs on the front lines. Like how do you see the ongoing evolution of the pandemic? I mean, how do you? I mean, of course, none of us knows, but I'm curious what your thoughts are about the next months to couple years.
Yeah, that's a great question, Ben. And I think that is important to touch on, perhaps where we are now and where we think it's going. But I think it's important to paint a little bit of color on the situation as it is right now as well.
Yeah,
You
absolutely.
know, to the point of what both of you had said, culture plays a big role, but you know, if you look at how the information is actually flowing right now, it's traveling in bits and pieces. So it's hard to act, for me, it's hard to change my practice based on that. It's kind of the information that you have. And so, you know, I practice up here in Canada, small towns and larger cities, but having that direct connection with providers, other providers on the front line, seeing what's going on in various states, Washington, parts of Asia, it helps. But at the end of the day, a lot of it is still ending up to clinical discretion, right? Clinical discretion all across the board. Do we test or not? You know, is this fitting a certain pattern or is it not? And often that ends up being a clinical decision by astute physicians on the front lines. And a lot of these cases are atypical. So it's a diagnostic challenge. You know, they're not all respiratory problems. I mean, one of the cases that has been coming up on a bit of a roundtable from some of our physicians in the area just today and this morning were various forms of rashes that were presenting, particularly in children in the pediatric population. It presents almost as a condition cardiac condition as well, that Roger would know, Kawasaki's disease, where that the skin presentations are, you know, petechiae and purpura. And so, you know, the question goes there, well, what do we do about that? Has anyone else seen this? And are they, you know, what are the assumptions that need to be followed here? Are all cases assumed to be COVID until proven otherwise or not? And so what you end up finding happening in a lot of these institutions and governmental bodies is it's not that any particular one was at fault, but if you take a look at like even some of the original CDC guidelines that came out for testing, it was essentially if you have a lower respiratory tract infection, plus recent travel to China within 14 days when it first came out. Now, a lower respiratory tract infection would be the equivalent of what you could call like a lobar pneumonia, consolidation in the lower part of the lung. And, you know, as we know now in hindsight, you know, I think the first case in California, the individual had no travel, right? So in that case, the hospital actually had to fight to get that testing done. And so what you find happening is that even though the guidelines update and change very quickly, a lot of the institutions kind of just take it as gospel, right? So what happens if an individual presents to our frontline, some of these clinics, with just a sore throat? Well, a lot of these mild cases weren't being tested, right? And that's what you could call an upper respiratory tract infection. So when you're not testing mild cases and the guidelines change, I mean, I think if you look in New York, even the first cases there, the introduction of the virus was from Europe, I think. And so to be able to sort of extrapolate out, you know, how things look, really depend on what we do today, which is it's changing. The information is changing daily and almost weekly. And so if I were to kind of look at where we are today, it's also very region specific. We're all on a different time scale. Things are rolling and very local specific. So you could imagine sort of how it's looking, you know, you can have many small outbreaks that kind of ebb and flow through our communities, likely seasonal and ongoing, you know, until, you know, what Dr. Lee had mentioned and others, you know, up until at some point there's a vaccine. In our healthcare setting, we have what's called a severity bias, you know, on the testing, right? It's sort of which individuals do we end up testing? And that clinical judgment really changes the, you know, the numerator and then ultimately the denominator as well on the numbers that kind of roll in. And so, you know, I would say that it's still a work in progress. Unlike what happened out in some of the parts in the United States, we actually up in Canada here did close all of the outpatient clinics. Family physician offices were all closed, and just due to primary care providers. So I'm a family physician by training. At that grassroots level, folks rallied together to essentially say, we need a COVID-19 specific assessment site because folks have nowhere to go to get testing. And these were in the early days, which, you know, a day is like a week in these times. And so weeks ago, when this assessment site launched up, we all ran into the same problems: shortage of PPE, shortage of testing. And so even to this day, while things do look much better, you know, a turnaround time for our PCR tests now are about 24 hours. Just about, you know, 10, 12 days ago, we were looking at about 3 to 4 day turnaround time. So things are improving, and I think that staying vigilant is very important.
That was really well spoken, Ray. Yeah, I gotta say that everything that Ray just spoke there rung true. The bits and pieces, the change in the information flow, and how we're grasping just to stay sort of abreast in terms of the situation. The only thing I want to add on top of that is, you know, what we've seen in how these algorithms work, right, and how it applies to the pandemic currently, and what you just spoke about, the denominator and the numerator, makes I have to absolutely, you know, bring that data out. So I looked at some of the data yesterday across the United States, and Dr. Eva talked about this already in terms of like how much recovery actually occurs. And it turns out that patients that enter into the ICU, potentially ventilated, only about 14% of them recover. And at our hospital, I got to say, I haven't heard of a single case that actually has made it through extubation. Now, we've seen a lot of YouTube videos, the cheering on of those patients that come out, but they are very few and far between. The very first case that we've seen that came through our hospital, that came after the Life Care Everett facility had all of the major long-term, that one major long-term care facility had all of those cases. Well, majority of them had actually expired. Unfortunately, they all passed away, and there were almost 30 or more of them there. And the case that came in at the exact same time with us, we were saying how lucky we are to have done well with that case, but he had an incredibly rocky course, and more than 2 weeks, potentially 3 weeks of intubation, being on the mechanical ventilation. So these patients are incredibly sick. And I'm not so sure, and I've studied numbers for a very long time, I'm not so sure if we truly understand what a real mortality, a global mortality rate of less than 1% really means, right? It sounds good, but we know that you know, a pandemic in the 1918 also had a very similar mortality rate, but it was devastating across the country with 50 million dead, 500 million individuals infected, right? And what I'm seeing here is numbers that are raging so rapidly that a couple of weeks ago, I might have said maybe not 1918, but now when I look at the numbers again, I'm rethinking of that, right? The trajectory of the University of Washington model, who predicted that the United States would reach 60,000 deaths, right? These are death rates. We're not talking infection rates. We're talking people dead. At 60,000 in July, we reached it 2 months, almost 3 months earlier, and now they have to go and fix the model, right? So what do these real numbers mean? And I take inspiration from what we learn from these artificial intelligence algorithms, right? My inspiration really came when some of these models really started working in Ray and my garage, right? We did this with our own bandwidth, with our own Kubernetes and so forth like that. But what we realize is that when we look at the percentage of accuracy, it could mean almost anything, because these algorithms can absolutely cheat. And so what it also means is that you really need to look at what the algorithms are doing. And so when we were doing agent type learning, right, we had to go back and look at, is the agent really performing? Is it really learning? Is it really beating all the games out there? And a score of about 80 could mean that the algorithm and the agent's randomly moving in something. But a score of 500, when you go back and look at it, and 600 means absolute optimization and overdominance. And so it's identical to what a virus is. A virus, you can think of it as an agent, right? At a number of point something percent. Yeah, it's probably like a flu or something like that, but maybe not. But when you have nothing to compare it to, right? We may have some SARS and some MERS and so forth like that, but for the most part, we have never seen a virus that made it to pandemic level in our lifetime, right? None of us have seen, maybe one patient in my entire career that might have lived through the 1918 era, but he was 103 years old, and but he was the only one. I've never seen anybody else like that. So none of us have ever had any comparison or any experience to anything that has occurred in our lifetime that is comparable to the 1918 total massacre. And so therefore the numbers that we're achieving now, I can't say that we can say that it's like that. And it's unlikely to be, because this thing made it pandemic. It made it quickly. It has a high R naught, and it has demonstrated that it could decimate 206 different countries, including a country that has total lockdown, right? China, bless their heart, exactly as you said, Ben, Chinese people, have culture. We love our family. And no matter what kind of dictator is sitting up there, they're Chinese people. They will take care of their family no matter what. And they tried their very best to do it. And it still decimated their country, right? And that's where the original data came from. And when I saw the original paper on the epidemiology and saw that they were able to reach 3,000 deaths in a matter of 2 weeks and outcompeted SARS in such a short period of time. SARS never went beyond a few hundred deaths, right? This thing made it to 2,000 deaths in 2 weeks and crushed SARS in terms of what it was able to do. That was a massive awakening in my perspective, in my experience.
So it sounds like, I mean, in terms of what you see on the ground now and what that implies for the future, I mean, it sounds like, I mean, understandably, you're seeing a lot of uncertainty in terms of we still don't understand fully, what the virus does to who in what cases, and we don't know all the details of how it spreads. But it seems like tentatively, the way you guys are looking at it it's fairly consistent with how Eva was looking at it. Like you're seeing, well, it's going to go away, then it's going to come back, it's going to pop up some here, it's going to pop up some there. And in this sort of circumstance, indeed, having effective tools for sharing information is going to be extremely valuable. And then tracking and tracing is also valuable. And it's going to be a combination of these technology-guided mechanisms that may help us keep the popping up relatively isolated when it happens, but then it's gonna keep being this sort of diffuse, hard to predict and grapple with problem until there's actually a vaccine. And that's
let me make a little bit of a plug there. Sorry to interject, Ben, but like as you're saying, so nth opinion, which is what we were working on, is sort of nth number of opinions. So any one opinion might be useful, case reports, you can call them. The accumulation of it's not a second opinion or a third opinion or fourth opinion, but to the power of n or nth number of opinions in aggregate seems to have been very helpful. It allowed us to set up assessment sites quickly by having large flows of information coming from folks who have already done it. They've certain jurisdictions have purchased out entire motels for isolation. They've emptied convention centers for isolation and quarantine. And so, very fortunate in Canada, our ICU beds, we have occupancy. We're at about 40 to 50% capacity right now in an over preparation. And I would always prefer to be over prepared than under prepared in these situations for, a wave, as what folks have coined it or termed it. Now, it's not all doom and gloom though, in a sense, because some of the early research that's coming out of animal studies, not factoring in what Dr. Eva Lee was saying, let's just assume that there is no changes in the structure of this viral RNA, right? Let's just assume that it's not going to be, it's not mutating to various strains, which is obviously a large and unfounded assumption. But for that particular assumption, there is some early evidence on durable immunity. We don't know the experiment that's happening out of Sweden right now, the so-called herd immunity and what's going to happen there. We know that they've experienced steep curves of infection. there's a lot of questions surrounding that. I guess the plug is, if there's any frontline physicians that are working and researchers in Sweden right now, we would invite them to join the project. It's called AskCo19, as in askcovid19.com, to really just start flowing that real-time information out of there, because questions like, how are they sequestering their high-risk individuals there, right? What are they doing with long-term care facilities? But, you know, what we have seen in some of these early studies is that you can have a PCR negative test and IgG positive antibodies, which suggests an immunity. And these were in test subjects that prior tested positive and had all of the common symptoms that you would expect out of COVID-19, recovered, and then when re-exposed to the virus, did not redevelop a positive PCR test. Now, that seems to be relatively good news, but there are some tremendous challenges that come out of that, because if you were to sort of try and re-demonstrate those studies in our populations in either America or Canada, the studies do show a very tight correlation, likely causation, we don't quite know, but with comorbidities. And so, you know, in Roger's line of work as a cardiologist, folks with myocarditis, congestive heart failure, high blood pressure, which is known as hypertension, right? If you start to extrapolate out and take a look at the data of all the high-risk individuals, you know, throughout our countries here, I mean, we have over 700,000 folks with end-stage renal disease, most and many of which are on dialysis. We have folks, you know, some over 40 to 50% of folks are classified in the obese population set. Not to mention secondary pneumonias, smokers. And so all of these high-risk individuals who subsequently test positive is a whole new trajectory that we're going to be unfamiliar with as it relates to, you know, this question of a second wave or not. So.
Yeah, no, that's excellent thoughts there. And I can tell you that one of the cardiologists at our facility has already obtained one of his antibody tests. And the question is that, what are you going to do if you have a negative antibody test? So that's, he's obviously very worried. He's one of our older cardiologists. In fact, we were so concerned about him, we actually took him off the workforce for a little bit. He's working from home now and seeing patients on video. So that's one massive hurdle. One of the few of the things that have concerned me a lot is that if this thing goes into the winter time, which I think absolutely Dr. Eva Lee is right in that this thing is looking as though the typical flu and typical SARS ended sometime in June and July, but they ended in June and July when SARS peaked in February and basically petered out by the end of February, right? This thing shows it started to kind of plateau a little bit after really aggressive measures, and it's only starting to plateau now, maybe, and then now we're reversing a lot of our measures as well. So, you know, and then in fact, the plateauing is at rates of deaths that are still over 2,000 deaths a day, right? And potentially infection rates that are over tens of thousands of infections per day, new cases per day. And that's because of the limitations of the number of tests that we're actually giving out. So who knows really how many new infections there really are. So, and in fact, we know that Washington has reduced it, and Governor Inslee has come out and said that we haven't been able to produce the total number of testings that we really want to test. So whether it really has peaked or not, we're not 100% sure. We have a limitation in the tests that we actually have. So that means that this is going to go along at least until the wintertime. And we know that once it hits the wintertime, a new cycle typically brews again, right? Now you're going back into the other viruses. You're going to commingle with epidemics of H influenza, RSV. Those are the typical flu viruses and upper respiratory tract viruses that occur at this exact same time, which also kill people and overwhelm the thing. And so it's going to be much tougher. And therefore, our ability to control COVID is going to be less again. We're basically repeat the cycle over and over again.
Yes.
So that's a major problem. So the contact tracing component of it is really interesting. So we've reached out to our state, and one of the ways that they're doing it with contact tracing, just to give a little bit of fact, is that every hospital in the nation that tests their patients with a positive test goes directly to the state. And the state will then go backwards and begin to elicit the contacts and then drill down and go from there. So far, we haven't had a lot of people that we've had to do it this way for down where I am right now. So that's really the beginning. To put a pitch in there, what I think we really need is that if the testing from the front end is not robust enough, it really gives us an opportunity in the AI world to develop something. And I know Ibi and I know Robin has developed something that reaches the level of the phones. Big kudos for them to complete that project. But if you can test without needing the test itself, if you're doing it purely electronically, you're not limited by the reagents, right? You're not limited by the number of swabs that you have. Everybody that has a phone can potentially test. And so if you can use AI to potentially test for whether you're positive or negative, that absolutely increased the robustness of contact tracing. Because if we don't have a case, you're not contact tracing, right? So
yeah, I mean, what we can do, we can use anomaly detection on, multiple signals that you get from, say, a Fitbit, a pulse oximeter, a digital thermometer, different plugins to your phone. We can identify using AI on these signals that there's something amiss in your physiological state, and that you're starting to get some kind of infection. Now, we don't, at this moment, at least our group doesn't have the data to tell if you're in the early stages of a flu infection or the early stages of a COVID-19 infection. I'm quite confident AI could tell that difference, but we need to aggregate the data and feed it into the AI to let it learn, right? And so I think there's a lot of roles that advanced technology and AI could play. What you guys are doing with Nth Opinion is incredibly important, and that's getting accurate information out there, and multiple voices presenting accurate information in different ways and from different perspectives to people who really want to know. And AI can help with that information filtering and information extraction and dissemination. So I hope, I would love to see some folks listening to this conference join in the Nth Opinion project to contribute to the open source code and help these guys build this incredibly critical application. On the other side, there's apps like the one we're building in Rejuve.io, spin-off of SingularityNET, which is aimed at using anomaly detection on input from all these medical peripherals to understand what's going on with your body even before you may notice it. And right now, we can tell that you're starting to get sick. But once you have more users for apps like that, you're collecting data from these users, and different users eventually will develop different medical conditions. Then you can potentially identify what's going wrong with them. It may never be as reliable as a medical test, but in situations where you aren't testing everyone, that can help you tell who really needs to get tested. It can be an important part of the story. So all these are part of this sort of digital sensorium that we're extending beyond the human body to help cope with these issues. I think the last question I have for you guys is, since our focus in this particular event has been mainly so far on sort of agent-based simulation modeling, like how do we use intelligent agent modeling to model and understand the spread and dynamics of COVID. Yeah, I'm curious, are there any special pieces of advice you guys would have to offer to those of us engaged in simulation modeling? And also, are there particular questions you guys might like to see answered that you think could viably answered by a more accurate modeling approach?
Yeah, I would have one point to add there then, and to address that question as well is, just for a little bit of context, when we have folks with these febrile respiratory symptoms and we triage them, I would say, from an AI perspective, looking at the data, pay particular attention to the sensitivity and specificity of these tests as these results come in, because I think moving forward, we really need to focus on the questions that we ask and the quality of those questions. One in particular is, what do we do if we have a negative test, negative viral test swab, right? So from a clinical judgment perspective, the answer is, well, oftentimes, particularly if they're in the emergency room or in the hospital setting, to test again. And what happens if that's negative? Do you test it yet again for an admitted patient? If you look at the sensitivity for the tests that we're using out here, you know, they're estimated somewhere about 60% or so. So, you know, 10% better than a coin flip for catching a positive test. So, I mean, what that kind of tells you is it doesn't quite function well for an exclusion test. It doesn't tell you much at all. In fact, we're trying to make it an inclusion by testing again to be sure, and then testing yet again, perhaps, because that first round of testing on initial presentation, we know that there's inflammatory markers associated with this. It's prothrombotic. So things like a D-dimer, fibrinogen, you know, standard chest X-ray. We have to keep the diagnosis, the differential diagnosis, very broad on this initial presentation. So as the data is being looked at, I think the more markers that you can get inside that data set will be helpful, because this is obviously something that human intelligence, as opposed to, you know, artificial intelligence, is not very good, analytical to be able to assess, you know, all of these variables. And then the next thing, you know, and the last thing that I would say in terms of questions moving forward, that I would challenge all of the listeners and folks that join our community, even non-healthcare workers who have joined our community, is to really think about that question, you know, what is it going to look like when doors start opening up again? Because to bring it back to the beginning of this conversation, as you see folks out in the parks running about without masks on, right? Well, what do we want it to look like? I feel that we have this amazing reset that is in some ways, you know, a great opportunity, in other ways horrific, and we're going to need to figure this out. So a lot of change is going to need to happen, particularly in the healthcare setting, as we rebuild our hospital systems, our communities, and our clinics. This is what it took, and this is our opportunity now to really take some of these technological enablers, thing that SingularityNET's working on. We didn't even get into in some future talk, you know, why the blockchain and decentralization of the data, so that we call it sovereign data, sovereign identity, and sovereign health, meaning you have ownership of your own health and your data. And if I personally obviously don't know exactly what it's going to look like, but I think if we have that vision and move towards it, now's the time to do that. So.
Yeah. I mean, you raised so many important points here. I mean, certainly it hasn't been our focus today, but in our collaboration on the COVID-a-thon with the Ocean Protocol and Decentralized AI Alliance, bringing together with NTH Opinion, SingularityNET, a bunch of other groups. I mean, we're looking at, if we're going to be gathering all this medical data about people, you know, which is what we want to do, so that AIs that we have can analyze the overall situation, can model the spread, can look at what therapies are working for what people, in what ways, and for what reasons. I mean, if we're going to pull all this data together, I mean, then who owns that data? Who controls that data, right? And the default in the medical community today is, you know, in practice, a hospital owns the data, or like a pharmaceutical company owns the data. And because how many people in the US have their own electronic medical record to share and use? Very few, even if in principle they have access to it. And if we're building a new generation of tools to do real-time monitoring of health situations, so as to combat a pandemic that's popping up here and there, and you want to keep it under control, can we make these tools so that data sovereignty is a foundational principle, and the information is controlled by the people who are generating it and who are using it to guide their own lives, right? And I hope that's the direction things go, and it's not that, you know, a few centralized tech companies are sucking in data and feeding it to centralized government simulation models. I mean, both for human rights and philosophical and political reasons, and because I think there's going to be more intelligence and better functionality in a decentralized network of, you know, computer scientists, epidemiologists, modelers, physicians, and so forth, than there's going to be in these centralized groups. So that's I'm glad you brought up that point, and I'm not surprised that you guys have provided us with more questions and examples than answers. That's one thing I've found as a mathematician and computer scientist who's been applying AI to biology off and on for more than 20 years. Biologists never can know anything for certain, and medicine is even further that way, right?
That's right. The
always
more we
Absolutely.
it's,
the more that we know, the more we don't know. The more we know,
yeah,
we
I
don't know.
mean,
Yeah. And
human body is very complicated, and combinations of bodies, which is what we're looking at with the pandemic, are even more slippery and complex to understand.
Yeah, my mentors used to say that that the evidence is evidence-based medicine is just 10% of the real world.
Yeah, I'll say this, Ben. I think that we have to have a lot more of these rendezvous moving forward, because I think it's going to be the people tuning into these videos and these calls, the people in these hackathons and on these teams that are going to make the difference and rally and recruit some of their colleagues. Because I have a significant fear, actually, as visceral and as painful as these experiences were globally, and the sacrifices that were made for some folks, filing for unemployment for the first time. For other folks, as Dr. Eva Lee said, direct family members, friends, contacts who have been had their first ICU admission or deaths, God forbid. And so, as visceral and as painful as that has been, we as a species have a remarkable amnesia. So it would be an unmitigating disaster if 2 years from now everything just resets back to the way it was, and folks forget the fragility of our healthcare systems and the siloed data centers that are housing a lot of the data that's needed to make progress in our industry. And so I think that we keep this going, keep the knowledge flowing.
Yeah, absolutely. I mean, it seems, COVID-19 is going to keep it flowing for another year or so, but we want to be sure that once this pandemic is finally conquered, there's going to be other public health problems popping up, potentially even something worse than COVID-19, although I certainly hope not. And we want to have the healthcare system, we want to have the decentralized blockchain-based information tools, we want to have the democratically controlled AI systems and agent-based simulations. So when something else comes up again, then we're on it, right? And the way to do that will be to keep building the networks that we're connecting through events like this and the COVID-athon.
Yeah, and
100%. I think one of the things that we've learned from the very beginning is that if you think you need it now for the future, the idea is to begin building it now, because the chances are, and from what I've been hearing from all the experts out there, is that the next one is likely 10 years away. And this one is not even over yet, right? And this one is looking into at least 1.5 years to 2 years before we have any sort of solution, if we're lucky, right? The developing a vaccine is, a lot of hard work, billions of dollars, and a heck of a lot of luck. And coronavirus is not going to give us immunity very easily, because it's one of those viruses that really doesn't mount an immunity. I was reassured by what Ray taught me about the data that comes from the IgG antibodies. But from some of the papers that I was reading before is that introduction of these boosters haven't been able to give an immunological response, as I've seen in other types of viruses that have actually had good success with the vaccine. So what that means is that imagine HIV, right? Hepatitis, right? These are the type of viruses that we are still trying to tackle with a vaccine. And it's been over 40 years, right? My mentors have come and have gone in an entire career, and we do not have a cure for HIV, short of antiretroviral therapies and so forth like that. And remdesivir, although positive, is still relatively slight in terms of what it can actually do. We're not sure if it's really going to be the big blockbuster that we need it for, even though the study came out, right? So we'll keep that in mind. And the other aspect is that the numbers that we were talking about before, I really wanted to sink into our heads, in that that this is a number, the mortality number that has been already given for COVID-19 is likely underestimated, but it has already decimated multiple countries, and it's here on our soil in New York that has ran ravage amongst that country. So if we were in that state, if we were waiting and still waiting for it, you know, we really shouldn't be waiting for it, because as we've seen with a lot of the timelines of real timeline displays of how the spread of the virus works in countries, one in particular is the Czech Republic that, Czech Republic, that has really demonstrated online in one of the cackle competitions, is that it just starts in one corner and basically spreads to all parts of the corner until it almost homogenizes in terms of the virus heat map. So there's no time like now than to do it. And I think one of the other things that Ray has taught me a lot about is built it well in the very beginning. So if decentralized, sovereign, permissionless, and ownership is the right path, that's what we should begin to build first. And one more answer to Ben, to your question is, what do we need for this agent-based thing, is that what I've noticed is how hard it is to get these agents into millions of users. We're now in the phase where we're trying to push up on the upward orders of millions of users, and it's not easy to get millions of users to handle these kind of algorithms. It's not easy to get it to work. It's not easy to get it in the hands of people that will use it and give us the data to do it. But we now have to, I think blockchain can give us that opportunity. I think we now need to think about how we need to do that, because as we've learned, even from, I mean, we saw it in China right at the very beginning, then we saw it in Italy, and then we saw it in almost every other country, is that once you hit a certain number in terms of the infections, in terms of, I was looking at the death rates, but once you hit a certain number in the death rates, an exponential curve comes out of it, right? So these are all nonlinear curves. So what that means is that, have we seen the end to the interactions and what the reactions are going to be when this thing hits 10 million, when it hits 50 million, right? Hopefully 50 million we will never reach. But if it hits that, we know that these nonlinear algorithms, these nonlinear agents do something very strange after certain numbers. So we absolutely need to capture this data now so that we know what's going to happen next. Because as we've seen in our own simulations and our own algorithms, that once you hit 15 million steps, something fantastic happens in our algorithms. It's something really beneficial. What I don't want to see is a virus do something that makes it even more superhuman than it already is.
Yeah. Well, that is a beautiful note to end our back and forth on. But if we have a couple questions from the commenters on YouTube, I think we could take a few minutes for that. But this has been it's been amazing discussion, and it is rare to find people who can pull together the doctor's hands-on view and the sort of the medical world with a broader view of the informatics ecosystem. So it's been a unique opportunity to have you guys here. Marchello, do we have any questions from the vast wisdom of the internet global brain?
The crowd wisdom. Well, basically, Ray and Roger already answered all the questions that we had coming from the community, and also the questions that I prepared to keep the conversation flowing. So the conversation has been very entertaining and interesting from our side. The sort of back and forth between you guys. So it was a shame to interrupt. So we have Deborah waiting. So I think that we can move to the next speaker. And if I get any questions from you guys, I will pass them along. Otherwise, we're just going to be too late with our program.
Fantastic. Well, thanks so much, Ray and Roger. It's really been an honor and a privilege here.
Yeah, no, the pleasure's ours, Ben. Thanks for having us. We'll have to do it again sometime.
Thank you so much, Ben. Thanks, Marchello. That's absolute pleasure.